Hello, good morning. Thank you very much for your invitation. This is a very simple case of transsubclavian case. This is a male of 86 years with several comorbidities, atrial fibrillation, anemia, chronic renal failure, high scores, and we had a very calcified aortic valve, and we have a consideration about the peripheral arteries. As you see, we have the iliacs and the femoral are very calcified and a short diameter. Since we don't have balloons and shock waves in our hospital, we don't have experience. We try the subclavian access, and we have our vascular surgeons are very experienced with subclavian access. We don't use carotid because we think that it's closer to the brain, so it will be more dangerous. I hope in a few years from now we have more experience and we proceed with a carotid. These are some cases that you preclude the transfemoral. If you have severe peripheral arterial disease, you have aortic tortuosity, you have extreme calcification or small diameters as ours. This is the measurements of the subclavian artery. This is our setup. We proceed from the left. This is exactly our setup in our. Okay. Here are the operators, the vascular surgeon, and now we'll proceed. This is our hospital. Half of the mountains are now burned. This is our new, we're proud of this, our new machine. So, vascular surgeon, this is the insertion of the femoral arteries. As you see, we proceed with one femoral artery for monitoring and the subclavian artery for the valve insertion. Usually, you can go with valve cross first, and then you go for with a sheath to have more stability. And in our case, we insert. This is vascular surgeon. We insert first the sheath, and then we perform the valve cross. This is our orthography. Some tips we use. You see, first we insert the sheath and then we proceed with the valve cross. If you need more stability, you can first perform the valve cross and then you do you go with the safari and you have more support in order to insert your sheath. And this is the okay, this is the second pigtail, and you see the hemodynamics of the patient over there. We make some measurements, severe aortic stenosis. We have here a balloon expandable valve. This is first the balloon for aortic dilatation. And then there are some other. This is the cone, the nose. If you go with a subclavian, you don't be afraid. The nose goes inside the left ventricle, but don't be afraid in order to have enough length to do your alignment. And once you see the valve, you remove the sheath in order to have a lot of space for your maneuvers and the alignment. Now this is the alignment of the valve. Now we have some difficulties. You see in subclavian we have short ankles, we have a lot of tortuosity, and maybe the walls of the artery is more soft and more fragile than the femoral, so you need to have more to be attention. So we remove the pigtail, make some. You don't need to have any other maneuvers of the delivery system. Okay. This is the pace, and we open the valve here. And this is the final aortography, hemodynamics. And then always, this is the general anesthesia. We don't use only local anesthesia. And then the vascular surgeon comes and gives us a nice picture of the subclavian artery. So this was the case. I wanted to present it to you. Thank you very much for your invitation.
Okay, thank you, Professor Stakos. Because of the time limit, there will be only one comment. Dr. McGuinness?
Nothing more. Congratulations. I see you have a very nice lab.
It was a very simple case for most of you, but
perfectly done. A very nice lab, a very good team. Congratulations.
Thank you very much.